procedures.
MRI suit comes as a NORA situation, not a
In
paper.
Nora, you have to take care of
Yeah, electronic this thing. But we are, when they say specifically, the question says OT, we have to talk only mostly about, I think, operation theatre problems. Do you agree?
yes, and in the
So if the
epispinal,
question is NORA and its a problem, then we have to talk all about that. But when it is only about OT safety,
okay.
I'll just share my thing.
Combined spinal epidural, they should be watching out for PDPH in the post-operative period. Uh,
It can be classified as, I think, environmental safety, patient safety, surgical safety, like that. I will just show you the slide.
and one frequently asked question is the pH and the balance is the anion gap, which is frequently asked. PDPH, post-spinal dural puncture, headache, anion gap is all frequently asked as short notes in national board.
So the OT safety, first we must know what are all the errors that can happen. Okay, so operating room errors are starting from the wrong
Static
patient,
electricity.
wrong operation, wrong site or site,
Yes.
unexpected intraoperative death, intraoperative complications, retained foreign bodies, operating room fires, mishandling of surgical specimens, patient injury due to position or burns, medication errors, transfusion mishaps, injury to the surgical team members. So these are the items that are considered as mistakes that can be happening. And if you are supposed to prevent all these errors so that patient will be safe. So the hazards which are also experienced are body fluid exposure from sharp instruments. So needle stick injuries, exposure to released particulates, exposure to waste anesthetic gases, possible exposure of chemical cleaning agents, slips and trips, fall indicator, exposures to radiation, hitting heads on the overhead lights, electrical shock hazards, fires. Okay? So these are called errors which are mostly man-made. These are hazards which are inherent to the operating theatre. Okay, so these two things you have to differentiate and first understand that. And what are the injuries that can, pressure injuries that can happen to the patient are, anesthetized patient is prone to pressure injury. It can be prevented by proper positioning, padding, and prevention of pressure, generating or avoiding pressure points. And the over safety pyramid, it is called the over safety pyramids, where errors that cause harm, these are all heard about, and we have to make sure that you prevent them at any level. Then there are errors and near misses. These are combined together. Our OR needs to have a system to capture these and prevent them. And process problems. Our operation rooms needs to capture signals that tell us we may have this and try to avoid this. So this is called the OR safety pyramid, which has these various layers or stages where we can identify the errors and prevent them. Prevention is better than safety, isn't it? So cure rather. So you have to identify which are all the problems. Of course, these are all common things which all we know. So if you use a unipolar battery, it will cause a spark and any inflammable gas will immediately catch and fire will be there. So that is, we have to take care of that. Surgical shock from all the instruments that we use, I mean, electrical shocks can also happen. And so these are the checklists that you should do for the safety of the patient or this entire team rather, not only the patient. So before induction of anesthesia, sign in. That is why if you see nowadays all hospitals have accreditation to NABH. They have made compulsory that the circulating nurse should read out the questionnaire to anesthetist, to the surgeon, and to the scrub nurse, isn't it? All of you would have witnessed that. They will ask you, what is the patient name? Are you aware? If all the team members should know who is the patient. So patient has confirmed identity, site, procedure, consent, site mark, or if it is not applicable, you need not mention. For example, if it is a laparotomy, you cannot mark the site. Whereas if it is a limb surgery or a cataract surgery, you can mark the site always. And anesthesia safety check completed or not, if the pulse oximeter is on the patient and functioning. Does the patient have a known allergy? Does have any airway or aspiration risk? The risk of blood loss more than 500 ml. These are all standard questions that have been asked in the before the induction of anesthesia to the anesthesiologist and to the surgeon also. And before skin incision, confirm all the team members have introduced themselves by name and role. Surgeon and anesthesia professional and nurses verbally confirm patient name, site, procedure, anticipated critical events. Surgeon review what are the critical or unexpected steps, what should be the anticipated blood loss. Anesthesia team, are there any specific patient concerned issues? Nursing team, has sterility been confirmed and all the theatre equipments are quite clean and sterile? As antibiotic prophylaxis has been given, yes or no? Is essential imaging displayed, yes or no? Whether a new CT scan or MRI scan has been displayed. So that is before the skin incision. And before the patient leaves out, you have to include the nurse verbally confirms the field, name of the procedure performed, instrument, sponge, needle count, all these things clear, how the specimen is labeled and has been properly sent to the lab, whether there are any equipment or problems that are to be addressed, and surgeon, anesthesia professional, and nurse review the key concerns for recovery and management of this patient. So this surgical safety list also has to be, this is described by the World Health Organization for the safety of the patient. And what are all the medication errors which are to be avoided are, because most of the drugs look very pale, I mean transparent. They are not colored except propofol, which may be milky white. All other drugs are mostly watery like. So there are chances of making mistakes, and so that has to be avoided by either color coding or proper labeling. And then read the label of any drug 3 times and the expiry date before you load the drug. So this is a very important thing to avoid drug error as well as improperly stored or improperly achieved drug. So what can we do to achieve a culture of safety in our ORs? Commit to safety, focus on safe operations, recognize high risk situations, view safety as a system of responsibility with individual accountability. Surgeons provide leadership, encourage teamwork, collect data, OR quality and safety committee to be reviewing all these things repeatedly, especially when there is a mishap occurring. It should be audited and reviewed, and you must see that it is not repeated in the future. Okay, these are all the important things that you have to write. So I have just given you the important points in this. You can elaborate on that. So apart from what Shobhita has told about the individual anesthetic agents, machines, and diathermy, OT temperature, and air quality maintenance, all these things you can add and expand. But these are all the major components into which you have to include your answer. Okay, if it is asked as a full question, you can include your what you have prepared into these headings and try to include this also so that it will be a complete answer. Okay, Jyotika?
Yes, sir. Yes, sir.
Okay. Next, shall we move on to the next question?